We have about an hour, so I might just get started. So, Ian, good evening, good morning, and good afternoon, everyone. Welcome to this webinar by the Canadian Spondylitis Association on COVID-19 vaccinations. My name is Graham Reid. I'm currently chair of the board for the Canadian Spondylitis Association. I live with both ankylosing spondylitis and Crohn's. I'm joining all of you in this circle from Musqueam, Squamish, and Tsleil-Waututh lands, what's currently known as Vancouver, and have the distinct pleasure of walking us through the next hour, and then also introducing our esteemed guest and kind of turning the space over to him. Before I do that, just want to kind of walk through the functionalities of Zoom. Many of you have already successfully found the chat function and have introduced yourself, at least where you're from. I see a very kind of wide diversity of spaces and welcome. We're excited to have you. We're at about 270 participants so far, and we're still slowly increasing. You'll see on your Zoom toolbar that there is the chat function, but also the Q&A function. In the Q&A function, you'll be able to ask questions, and we'll, myself and some staff, our executive director and our social media specialists will help kind of monitor and triage those questions so Dr. Haroon can respond to all of them in the best way possible. So if you have these questions, please feel free to introduce or just put them into the questions and answers. So, with that, I think it might be a good time to get started. And, clearly, one of the things that we want to start with is just sending our strength and support to all of you as you navigate these uncertain times. And, I don't think often we take enough time to acknowledge what we're all collectively going through. And so wanting to send kind of our best wishes as you, as your family, navigate whatever challenges there are. And, hopefully we can continue to see light at the other side of the tunnel, which is partly what this conversation is about. And we know that the vaccination rollout is obviously something that's top of mind for everybody. We have, luckily enough, we actually have international perspectives in this chat. And so presumably this is a similar process that different folks are navigating. And so, we want to make clear at the CSA that we are here to help you make informed choices, recognizing that the primary place for you to have conversations about your health is with your specialist and with your doctor. So these are intended for information and intended to help inform, make those good choices. We're really lucky to have Dr. Haroon join us and share a little bit of background from his perspective, and also include some background from the Canadian Rheumatology Association, who have released a position specifically on the vaccines that he'll be able to speak to on that specifically. We at the CSA have shifted a lot in the last year and want to lift up the work that Wendy has done, who is our executive director, in particular, in helping that shift. And we're continuing to grow the resources that we have on our website, spondylitis.ca, inclusive of webinars that we hosted at the start of the pandemic all the way to now. And we're looking to continue that momentum to make sure that we contribute to the decisions that you and your families are making as you navigate, not only this current uncertainty, but the ongoing uncertainty of living with, chronic illness, much like myself. So with that, really excited to have this space to share it with Dr. Haroon, and also to share it with all of you as we, embark on the next hour or so. We want to start our presentation with thanking our esteemed funders, all of who help put on events like this and help kind of facilitate the resource that the CSA is continually developing into. Many of those resources are now still found on our website. For today's session, we kind of have, three broad objectives. One is just to share a little bit about what the CSA is and what we do. We know that the bulk of the time that we want to spend together is based on hearing from Dr. Haroon, and then have kind of a lively and open question and answer session, noting that we already have about 15. We have also a number of questions that were asked during the registration process that we'll try to get to as well, and likely many will come. So bear with us as we kind of navigate the numerous different questions that everybody is sharing. I'm really happy to say that we are over 300 participants, and I think that's a testament to the importance of this conversation. So, we're lucky to be joined by Dr. Nigil Haroon with a long list of achievements and affiliations, all of which are things that likely he will discuss in his presentation, but want to, highlight first, his role in the Canadian Rheumatology Association as Vice President, his co-directorship of the spondylitis program at the University Health Network and the University of Toronto, and also his medical expertise, not only a doctorate of medicine, but a PhD from the University of Toronto, all of which position him as an important contributor to this conversation, and also to responding to as many questions as we can get to. Just before I turn it over to Dr. Haroon, just want to, for those who are joining the CSA for the first time, share just 30 seconds about what we do. We are the only national association in Canada that support those living with spondyloarthritis, ranging all the way from psoriatic arthritis to what I have, for example, in ankylosing spondylitis. We are not-for-profit. We have a functioning board, a highly functioning board made up of majority folks living with spondyloarthritis or in close proximity. We have our social media experts, as well as Wendy, that help advance the credibility of the organization, and we have international partners. 2 years ago, we embarked on a strategic planning exercise, one of which that identified 4 strategic pillars that we advance: education, awareness, advocacy, and patient support, all of which I think are particularly important in this time. And without spending too much time, just want to share for those who are looking for additional support in these times. We do have successful support groups across Canada, 14 in total, many of which are moving online and providing that virtual peer-to-peer support. It's important just to kind of create that space for one another, and listen and learn from those living with similar conditions. So I'm going to stop there. Really appreciate the over 310 folks that are on the line, with additional likely tuning in on Facebook, and stop my screen share and turn it over to Dr. Haroon. And just want to say, on behalf of the CSA, we're incredibly grateful for you providing this time to us, and also providing this resource to the hundreds of people on the line. So really appreciate that, Dr. Haroon, and look forward to having this conversation with you in the coming hour or so.
Thank you, Graham, for that kind introduction, and thank you to CSA for all the great work that you are doing. Indeed, we are partners from the beginning: SPARC, the Spondylitis Association, Spondyloarthritis Research Consortium, and the Canadian Spondylitis Association. And together we have achieved quite a bit over the years. And kudos to you for organizing a lot of these seminars and talks that are helping patients, and also our annual patient information workshops that we conduct together also are quite informative. So thank you again for this opportunity. It is an important topic, and clearly you can see from the interest in the registrations, over 700 people have registered for this event, and clearly there is a lot of anxiety out there. There's a lot of hope out there with with the vaccines, and my goal is to just touch the surface, because this is a rapidly evolving field, and what I may be saying today may not be true a week from now because of the rate at which the information is coming in. But at least based on the information that we know as of today, if we can scratch the surface at least on the immunology of COVID-19 response, and then what the vaccines are doing, and hopefully address a few questions that are coming in. So I work at the Toronto Western Hospital, and probably the easiest way to connect with me would be through Twitter, because I'm quite active there. I look at Twitter at least once a day, so maybe that might be easier. If you go to at Nigil Haroon, that might be the easiest way to connect. Before I start, I should also disclose that I'm a consultant for a number of companies, and some of these companies also are working in the vaccine area for COVID-19. Okay. So this is the first thought for today. Let's start with COVID-19. And I would say that it is just, it's not just another flu. This is where we are. This is data from today, and I got this from the WHO site. You can see the number of new cases today, 312,000 new cases, over 94 million confirmed, over 2 million deaths. Clearly, this is not just another flu. And this is data from Canada. We are closing in on 20,000 deaths in Canada. When we talk about COVID-19, something else to keep in mind. So by taking a vaccine, we are not just preventing acute COVID-19. This is an example of an individual who had COVID-19, completely recovered, and several months down the line, this is from Italy, he is still not able to have a complete recovery, and is struggling for breath. And so COVID-19 is not just an acute viral infection. There are many long-term consequences of COVID-19 that have been identified. Yes, it's not there in everybody, but a few patients do have these long-term complications. Here is an example of something that we don't think about: neurological complications of COVID-19. If you look at mental health issues, significant 33% of patients have reported significant stress, anxiety, and sadness following the onset of the pandemic. And look at these neurological consequences that have happened in patients with COVID-19, right from the Guillain-Barré syndrome to strokes to severe encephalitis. So a lot of things outside a regular viral infection can be seen with COVID-19. This is a structure which I'm sure almost everybody who is on the call will be familiar with. I just wanted to point out one thing: the outermost structural component of this virus is made by the spike protein, and that is what is being targeted by our immune response, and that is what we are getting through this vaccination. Okay, and what the spike protein does is it gets attached to the receptor called ACE2 on the surface of the cell. And you can see what happens here. This is an example. This is just an electron microscopic picture to show you the actual virus. Now, this is not the SARS-CoV-2. This is the origin of the previous 2003 SARS-CoV virus, and how it gets attached to the surface of the cell, and it goes into the cell through the surface. So it's just to show you actually how the virus gets entry into the cell. Once it enters the cell, the RNA is released. So it's an RNA virus, it gets released. And what happens within the cell is it produces a lot of proteins and peptides. Our immune system starts off with this antigen presenting cell. So this antigen presenting cell, as the name suggests, is a cell that will pick up anything that is foreign, that it finds foreign, and it presents it to our immune system. So one of the first cells that detects such a foreign antigen present in the antigen presenting cell is a T helper cell. So as the name suggests, it helps the body to develop a strong immune response. It does so by triggering cytotoxic T cells. And as the name suggests, it is a toxic cell. It'll attack any cell that contains the virus and trying to get rid of the virus, and along with it, the cells also. The T helper cell also helps the B cell to produce a lot of antibodies, and these antibodies will directly attack the virus. And also these antibodies can also prevent further entry into other cells because, as you know, the spike protein is required to enter the cells. So if you have an antibody against the spike protein, it doesn't enter the cell. So further deterioration is prevented, and also the antibodies bind to the virus and kill the virus. So you have these two arms that are working against the infection, the T cell arm and the B cell arm through antibodies. Okay. So here is a very good study. This was, I got this when it was a preprint, and now it is already published in the journal Cell, a very high impact factor journal. It's a study on 185 patients who had COVID-19, and around 41 patients were followed up over 6 months. And to cut to the story short, this is what the message is from this study. You look at the antibodies against spike protein, it is more or less steady over the period of 240 days, although there is a small decrease over time. However, if you look at the B cells, the memory B cells, it is steady. And in fact, in most patients, it is actually higher by 240 days. So this gives us real good hope that long-term memory, at least up to this period of 240 days that was studied with an average of around 6 months, there seems to be a long-term memory, especially in the memory B cell compartment. Now here is a look at the T cell compartment, which we mentioned. So the two arms, the B cell and the T cell. So you look at the T cells, and you can see that the effective memory T cells also increase over a period of time, and it is present at least till they are 240 days that was studied. So our immune response is excellent. Our immune response seems to last at least for the period that we're able to study now. Now, do we have an immune response in year 2? We don't know yet. These are the vaccines that are currently available or in advanced stages of production. You can see these are the two that are available in Canada. Both are mRNA-based vaccines. One is the BioNTech Pfizer vaccine, and the other one is the Moderna vaccine. You can see the names here, the primary developers, and you can see that the Pfizer vaccine is actually there and approved already in multiple countries, while the Moderna is restricted to a smaller number of countries. There are other vaccines that have been approved. For example, if you look at the vaccines approved in China, there are 3 vaccines approved in China, Sinovac and 2 Sinopharm vaccines. In the Middle East, it's mostly the Sinopharm vaccine that is currently being distributed in very large numbers. And in Russia, you have the Gamaleya Institute vaccine, the Sputnik V. And also just yesterday, I saw a news article come in that the second vaccine from Russia, I believe it is the peptide vaccine. I'm not sure which vaccine it is, but the second vaccine which Russia was developing is 100% effective. I've not seen any data. That was just a news headline that I read. Okay, so how effective are these vaccines? And again, we all know these numbers after repeatedly seeing all these news headlines. The 2 mRNA vaccines that we have in Canada are around 95% effective. And this is the Gamaleya Institute one, almost similar numbers. And the AstraZeneca Oxford one is average of around 70% efficacy. These are the agreements that Canada signed, and a lot of people were saying we signed up for way more vaccines than we need, and we're sort of keeping them in stock, not leaving it to other countries. But the ground reality is not really what was seen. We are not getting enough vaccines, and if we had enough vaccines, hopefully the number of people who have received vaccines over this period of time would have been much higher. At the rate this is going, I think by probably midsummer, all the priority groups will be completed and will be open to all the other non-priority groups. Hopefully by April, May, things should start opening up by the rate it is going now. So how do these vaccines work? So it is an mRNA vaccine. What it means, it is a messenger RNA. So it brings a message to produce a protein. So clearly from that itself, you're only getting a message to produce a protein. You're not even getting a part of the virus. And for it to be introduced into the cell, there is a lipid coating, and this RNA is present inside the lipid coating. Once injected into the body, it gets taken up by the cells, and within the cells, using the cell's own machinery, the messenger RNA gives the message and the cell produces the protein. It gets presented on the surface, and just as we saw with the natural infection, our immune response starts working because this particular spike protein that is presented on the surface triggers our immune system. And just to show you this mRNA vaccine, there's a lot of talk around that this is a very new technology. In fact, it is not a new technology. The discovery of mRNA happened in 1961, and the discovery that it actually triggers the immune system was way back in the early 1990s, with the first clinical trial of disease transfected for cancer with mRNA was way back in 2002. So a good almost 2 decades back. And here is when we had the first mRNA vaccine for an infection. So this clearly is not a new technology. Yes, for infections and for clinical purpose, this is probably one of the early ones to be approved. And these are some of the ingredients. I will not be going into details of this because I don't think that's the point of today's talk, but you will see that there is a lipid particle and there is a pegylated particle, and then there is the mRNA. So these three are the cardinal parts, as I mentioned from the diagram. So the Public Health Agency of Canada, so I'm missing the health there, apologies. The Public Health Agency of Canada has certain principles for COVID vaccine administration and distribution. And this is primarily driven by data, and then transparency in the process. Fairness and equity is very important, and also there should be consistent reporting of vaccination status. And based on the NACI guidelines, you'll see that there is a prioritization for receiving vaccines, and the key populations, the first key population is a high risk of severe illness and death, and that's why long-term care residents were the first priority. And after that would be the people most likely to transmit the infection, and those will be the healthcare workers and personal support workers, and then the priority decreases here. And here is an example of how the British are doing it. This is from the BBC. You'll see that care home residents and workers will be the #1 priority, followed by elderly people who are outside care homes, and it goes down based on age. Okay, we'll come to the last part before we go to the questions. So the Canadian Rheumatology Association came out with this recommendation on vaccinations very recently. So the first recommendation was that patients above 70 years old, they are considered high risk for severe illness, whether they have a rheumatic disease or not. And so vaccination should be considered regardless of what the underlying diagnosis is. So that's the first recommendation. And in those below 70 years of age, vaccination should be assessed on an individual basis, taking into consideration all potential risk factors, including occupation. And it is very clear that till date, there is no evidence that DMARDs or the presence of a biologic appears to increase the risk of either getting COVID or getting severe COVID. So that is why they have not recommended vaccination of these individuals as high priority. That is the reason. In patients with higher risk of severe illness, for example, those who are on corticosteroids, vaccination should be considered. Again, this is not a very high priority population. This is specifically for the pediatric population because this was tested in those above 16 to 18 years of age. So we don't have data as of now, although trials are starting on the pediatric population. So this has to be considered on a case-by-case basis. There is no recommendation for withholding DMARDs at this time, although you will see that for the regular flu shots, we do hold a methotrexate for a period of 2 weeks minimum, sometimes 2 weeks before and 2 weeks after. So that is, I think, a good practice before the vaccination, and that is reflected in this recommendation. These are the adverse effects that have been reported. You will see that the very common adverse effects may refer to those that are present in more than 10% of individuals that are receiving the vaccine. And common means occurs in 1%, but less for 1 to 10%. So you'll see that most of the common adverse effects are routine adverse effects that we see with any vaccination, for example, at the injection site. And Pain at the injection site for around 10 hours to 12 hours was the only adverse effect I had with the first shot of the vaccine. I didn't have any redness, reported swelling, lymphadenopathy, fatigue. These are all well-known adverse effects of any vaccine, because as your immune system is responding, and I think this in fact shows that you're getting a good response to the vaccine. Some amount of joint pain has been reported by individuals. Fever has been reported, and these are things that can be managed by a simple Tylenol for maybe a day or two. Okay. Finally, I would like to stop with this thought. Vaccines really do not stop pandemics. If you're thinking vaccines stop pandemics, that is wrong. Vaccinations do, right? So let's roll up our sleeves, and when we get the opportunity, I think we should go ahead and get the vaccine. That's all I have.
That's fantastic. Thanks, Dr. Haroon, and really appreciate how comprehensive your presentation was. I think there's a wide number of questions that are emerging, and I just want to assure folks who have asked questions in the Q&A, when we've moved it over to being dismissed, it's only because we're tracking the questions and trying to kind of find similar themes. Sure. So I wonder if one thing that we could start back to is the biologics question. And I think you had indicated that in number 3 of the recommendations from the CRA, there's data out there with no kind of extra adverse impacts for those taking biologics. I wonder if you could just maybe clarify or provide a little bit more detail on that. And then after you do that, just maybe some clarification on timing. There are a number of different questions on, before biologics or after, or so any guidance that you can provide would be super helpful.
It's a very important question, and something which I'm addressing on a daily basis. That we are one of the largest programs in probably in the world, with around 1,500 patients. We have close to 500 patients on biologics at our center, and everybody has this question: what should I do? Should I hold my biologic? Is the first question, and second question is, if I'm on a biologic, will I get a response? And third question usually is, okay, if I'm not stopping the biologic, is there a good time to get the vaccine? So the general concept is that when you're immunodeficient, I'm not saying that people on biologics are immunodeficient. There are very strong immunodeficient conditions where you don't have enough T cells, or you don't have enough antibody for responses. And even in those severe immunodeficiency conditions, which could be congenital, which could be acquired, HIV would be an example where there is significant immunodeficiency. Even in those significant immunodeficiency conditions, if the vaccine is not live, an example of a live vaccine would be an MMR vaccine, or a rotavirus vaccine, or an oral polio vaccine, yellow fever vaccine. These are examples of where the live virus is being injected. It is not a good idea if the individual is immunosuppressed. Now, this is not a live virus. This is not a part of a live virus. This is only an RNA where a signal is given, where our own cells are producing a very small part of the viral peptide. So viral protein, the spike protein. So even if individual has a strong immunodeficiency, I don't think it's a contraindication. The second part is, if you're on a biologic, you are not at that level of immunosuppression, right? So there is some immunosuppression, but those who are on biologics have not been shown to be at increased risk of even the natural infection with COVID-19. So it is safe to take the vaccine. Now, is there a good timing if you're on a biologic? I would think that to give the best chance of our immune system to be active and respond and create an immune response against COVID-19, you can probably try to target mid-cycle. So for example, if you're on an infusion of a biologic that is every 4 weeks, let's say, for example, you could probably go with the end of 2 weeks. So you have a 2-week period before the last infusion and a 2-week period after the vaccine. So you develop some immune response before you get the next shot. I don't think you need to, postpone the infusions or anything based on the data that we have. As I mentioned, this is a rapidly evolving field. Things may change in the future, but as of now, the recommendation is you don't need to change anything. However, there is one thing, if there are individuals, I know this is done by the Canadian Spondylitis Association, but if there are patients out there who are having a different rheumatic disease who are listening in and they are on rituximab, for example, that may be a different situation because rituximab, wipes out the B cells and we may not be able to generate a sufficient amount of immune response. So it's something that individually they have to talk with the physician. If you ask me personally, I feel that rituximab stays in the system for quite a bit. The effects last long. Protection against COVID-19 is much more important. So go ahead and get the vaccine. What I would probably do is wait and see if I'm developing an immune response. If I'm not developing an immune response, maybe I may need a booster dose at that time.
Thanks, Dr. Haroon. And just a related question. There were a few about DMARDs or methotrexate. And you had indicated just in the recommendations, I think number 6 or so was about maybe delaying methotrexate. I wonder if you could just speak to that quickly.
Yeah, again, specifically for the spondylitis population, methotrexate is not a drug that is commonly used, but there are individuals who are on methotrexate as well. And for other rheumatic diseases, methotrexate is a very commonly used drug. So we are following the practice that we do for flu shots. So there is some data out there to suggest that if you delay methotrexate by a period of 2 weeks, you get the body's immune response is better. And so you get a better immunity against the spike protein. So however, having said that, if stopping methotrexate increases the risk of a flare, if there are individuals who are just barely under control, and there is a significant risk of stopping methotrexate, that is something which you have to discuss with your rheumatologist before this decision is taken. But if it is a well-controlled disease and you're able to stop methotrexate, ideally I would stop it 2 weeks before the shot, and then restart 2 weeks after getting the COVID vaccine.
That's great. Thanks, Doctor. Shifting gears, there were a number of questions about efficacy, and I guess I'd be interested in if you have any thoughts on, the efficacy of vaccines on, folks living with spondyloarthritis, and whether or not there are differences between those who live with spondyloarthritis and those who don't.
Yeah, I don't expect to see differences in individuals with spondyloarthritis. Will there be differences in individuals who are on biologics? It's too early to say. There might be a mild reduction, but will that make a meaningful difference in the response and protection? I doubt. So because we do take flu shots in patients, and it is in fact a recommendation that you take flu shots every year, even if you're on a biologics, and those individuals receive the same level of protection as the others. So I don't expect there to be a significant decrease in the protection levels.
That's great, thank you. I guess the second part of that is, I think there has been some indication that there were certain populations that were excluded from certain parts of the clinical trials, and I wonder if you could just kind of speak to that quickly.
Yeah, so well, in a clinical trial situation, obviously, when a clinical trial is designed, there is the science aspect of it, there are the ethical aspects of it. When you look at the ethical aspects of it, it is not right to exclude a particular group, but you have to look at the practical aspect of things and the safety and proven things. So generally, when clinical trials are done, 2 groups of people are not included. One is kids, and the second one is pregnant women, because we are not sure about the safety in these populations. Once we establish the safety of any medication in the other populations, then once we find that it is safe, then we extend the clinical trials to children below 16 years of age and to pregnant individuals. Right now, because of the seriousness of this disease, the trials have already started in the other populations. So it is a delay, but it's not a delay that we are usually used to. So hopefully we'll get very rapid data. I don't think we'll need to wait as much as we needed to wait for the other adult population. So hopefully we'll get data very soon in the next few months.
Great. And I guess one of the points you touched on there is just about safety. And we've had a few questions just in the chat about whether there are any studies about, flares or side effects after the vaccination, or are we slightly too early to determine that?
Yeah, I don't. I did not come across any confirmed serious adverse effects. There were no deaths, for example, in the trial. Now, people may be referring to the report from Norway, right? And from the report from Norway, the headline was written very badly, so that's sort of sent a wrong message. Um, what happened in Norway is that a number of individuals, if I remember the number correctly, it was around 30 individuals, 23 or 30 individuals. There were almost to that number, high number of deaths in the individuals who received the vaccine. However, that was totally, the context was not there. These were individuals who were 75 or 80 years and higher of age and were quite frail and almost end of life. And the data just came today, just suggesting that yes, there were 23 deaths in individuals who received vaccines, but keep in mind, we are giving vaccines to 80 plus and above in long-term care homes and who are frail. And in that particular population, there are um, 55 deaths every day in that population, right? So if you're injecting individuals who are almost at end of life, naturally there will be a number of deaths. You can't really link it as a cause or as a direct cause of the vaccine. That is what we know currently, and they're analyzing the data, and hopefully we will have more clarity soon.
Yeah, that's great. I think that sort of clarification is important as, all of these things kind of are obviously something that's top of mind. Um, I guess you had mentioned the inclusion of pregnant uh, women and or women identifying or youth. I wonder if you could just speak to the participation of like immunocompromised folks and any of the safety and efficacy studies that you've read or interacted with so far.
So efficacy studies, and can you repeat that question? Sorry.
Oh, I was just wondering the inclusion of immunocompromised
Okay.
folks
So
in, yeah.
obviously, when you design a clinical trial, you exclude individuals on immunosuppressants and who are immunodeficient. So unfortunately, we don't have any strong data on that. But as the regular routine vaccinations continue, I'm sure, especially there are very large registries around the world, and I'm sure we will have quite a bit of data in the next 6 months or so on efficacy and safety. I was just reading one of the comments from to the panelists. It is not there. It is written by an individual who is a healthcare practitioner and also has axial SpA. In the interest of privacy, I'm not naming the person. And the individual has said that they got the vaccine and very minor side effects, 1 to 2 days, and saying that vaccine side effects are limited to only 1% of the population, if that helps ease everyone's fears. So there, right. I was just reading that when you asked the question, that's why.
Yeah, that's perfect timing. I guess there's also been a few questions about the CRA recommendations, and I wonder maybe as a starting point, you could just talk about, the types of discussions that the CRA has when developing, recommendations like that, and how do they relate to, for example, the European League of Rheumatology.
Yeah, it is important. It was not an easy task. Coming up with a statement and definitive guidelines when the field is rapidly evolving and there is very little that we know about a lot of these things, right? The primary intent of coming out with a guideline immediately was because we were getting a lot of phone calls saying that because I have a rheumatic disease, I'm being excluded from the vaccine. Because in the guideline, there was one item which said that if you have an immunodeficient condition or if you have an autoimmune disease, then the vaccine should not be administered. So that crept it somehow into the national statements. So we had to counter that by saying that we are vaccinating individuals with rheumatic diseases and autoimmune conditions for ages, and there have not been any problem. Just because they have a rheumatic disease or an autoimmune condition, they should not be, there should not be any discrimination against these individuals. They should get the vaccine. So that was a primary intent of coming out with the statement. Now, the reason why it was made in that particular order with the strength of recommendation is because we are not going to get vaccinations for those below 70 anytime soon, because the priority was those above 70, long-term care and healthcare workers. So we were essentially, trying to send the message that these individuals can be vaccinated. They should not be discriminated against. At the same time, we have got some time to see if any new data evolves to come out with stronger recommendations for the rest of the population. So that was all that was there in the statement. It definitely, we are in favor of vaccinations for rheumatic disease patients.
Yeah, that's great. I guess a follow-up question is just for those who have, multiple comorbidities, like myself living with ankylosing spondylitis and Crohn's, is there any things that I should think about in, contemplating or dialoguing about the COVID vaccines with my specialists?
Yeah, I again, it'll all come down to the medications you're on and the level of control of disease, right? So the ideal timing for vaccination is a status of very good control of disease activity so that your immune system is ready to respond to the vaccine and generate a good immune response. So if there are like two conditions like arthritis and colitis, or arthritis and bad psoriasis or something like that, then ideally all comorbidities should be well controlled, and this goes for any disease, not just for rheumatic diseases. So that's the only thing which I would recommend.
And speaking about control, we had a few questions just about whether there could be any linkage between taking the vaccine and experiencing a flare. I wonder if you could speak to that.
Yeah, so this thought around having a flare following vaccinations really came from the days we've started using adjuvants for vaccines. So what an adjuvant does is it sort of preps the immune system to have a hyperimmune response when exposed to an antigen. So that way you get a very strong immune response and there will be good protection. So an adjuvant would essentially trigger the immune system in a way outside the actual antigen that we are giving. This vaccine doesn't have an adjuvant. Okay, so it is not an adjuvant vaccine. So that way it is not at all an issue. And I've not heard any reports of significant rheumatic disease flares after this vaccination. We will see. I don't think it's a big possibility, but again, these are early days. We will get data soon.
Yeah, that's great. And it's great to hear just, the experiences of those in the chat, but also those on our Facebook page. There's been a few healthcare practitioners that have taken the vaccine and have, shared their journey with other folks.
And I thank them for sharing the
yeah. I guess, there's kind of the lingering question that I think, many folks may be thinking about is, the longer term effects of taking the vaccine. So I'm wondering just if you have any like preliminary thoughts on that, recognizing that, this is the start and that more data will come to help respond to, what are those longer term effects?
Yeah. So long-term effects of vaccines really, first of all, it's very difficult to prove it's an effect of the vaccine. And for almost all vaccines that we have seen, the peak of 90% of the side effects that we see are within the first 30 days or 1 or 2 months, right? So thinking about 5 years from now, 10 years from now, how are we going to prove that if something happens, it was related to the vaccine? So I don't think that kind of a proof is ever going to be possible. Maximum you can think about maybe a 6 months effect, or unless you can directly link it to a direct effect of something that was injected, which I don't think is going to be possible. So right now, I think the priority really should be controlling this pandemic, which seems to be going crazy. And with the new variants appearing, it is looking quite a bit of a problem. So we have to get this under control before more and more variants that actually start escaping the vaccines that we've got start appearing. So action needs to be done today.
Yeah, and I think we're getting close to the end of our hour, but I think that point is worth reiterating. It's, not only about vaccination, but I guess it's also about action and kind of individual actions that we can take. We know all of the things that we can do personally within our bubbles that can control the spread of, COVID-19. And so, part of this is recognizing that the vaccine is one part of a larger strategy in, what we all need to do in terms of kind of getting those transmission and community spread under control. I wonder if you could, we've spoken about a lot of different things, and I'm wondering if maybe you could identify the kind of, 3 to 5 key messages that you would want folks to kind of go home with. I just want to say that, in the chat, our folks have actually just put the link to the CRA vaccine position, and encourage everybody on the line to go read that for yourself, just so that you can see where the CRA is coming from. But yeah, any kind of final key messages that you think folks could.
And I would say that these are unprecedented times. This is something which we never dreamt of even going through, right? It's almost out of a Hollywood movie set. Like 2 million deaths in a few months. Can you even imagine when this started? We knew this was big, but this big, and now with the vaccines rolling out, with the new variants coming in, we have to really act very fast, and each of us has a responsibility. There is something which I saw in the chat which also needs to be addressed, because mixed messaging during the pandemic has been a problem throughout. The question of masks is an example, right? Because initially there was no strong proof that mask was needed, and there was significant shortage of masks. And later on, when the proof came, people started asking, why didn't you say masks were important before? But so that kind of a mixed messaging has a problem. So another major problem of mixed messages is coming now, because even after vaccinations, people are asked to observe public health measures. So people are thinking, oh, maybe the vaccine is not effective. That is why I have to do public. So it is not that. Vaccines are very effective, but there are certain things that we don't know about vaccines. For example, if you have a vaccine today, 5 days from now, can you harbor like a few viruses in your nostrils, that when you sneeze or something, it could potentially infect somebody else? We don't know that. That's a very remote possibility. Considering the gravity of the situation, we should even consider such an extreme situation. Now, the other example is, you're vaccinated, very good, you're completely healthy and protected. But if you're going in an elevator, you touch an elevator button, your fingertip is not immune, right? You may carry a virus, and if you shake somebody else's hand, you're transmitting the virus immediately. So that's another possibility. So all these things should be kept in mind. And because of the gravity of the situation, even after vaccination, until that herd immunity level of around, let's say 80% of the population is immune is achieved, we should still be, really careful in how we interact with people. Maybe, no, it's just a matter of time. The masks will come down at some point, but just a little bit of patience. That's all that we need.
Yeah, and thanks, Dr. Haroon. Like, really important point that's worth reiterating. Technology, like development and vaccines, can only get us so far, and our individual and collective behaviors in doing the things that we do know mask wearing is effective, we do know distancing is effective, and so part of it is making sure that we continue those trends as long as necessary, and also continue acknowledging that we're all navigating this kind of uncertainty together, right? It's not like any of us really know the answers, and hindsight is always 2020, and always something that we can reflect on. So there's about 8 minutes left. There was one final question that I think might be useful, just about like vaccine selection, and whether there's one that we should think about for those who live with like autoimmune conditions, or are they equally appropriate for us?
Based on the data right now and the 2 available vaccines in Canada, I don't see any difference between them as far as for someone with a rheumatic disease or without a rheumatic disease. I don't see any difference. The major difference is really in the way it can be stored and the ease of transport. So that is why, appropriately, the government is prioritizing the Pfizer vaccine for the major centers that have the big the big freezers. And the Moderna vaccine is a little bit easier to transport. So that is being prioritized for the distant community. So it can be transported and given easily there. That is the only difference that I can see. Otherwise, whichever vaccine comes first at your door, take it.
Yeah, great. And like a good message to end on, the kind of point about, vaccinations, and pandemics. And, there's one comment that I just saw in the questions about, if we won't get rid of COVID, it doesn't mean that we won't get rid of COVID if we get the vaccine. I think what both of us were trying to say is just that the, full eradication of a virus like this takes time. And it takes all of us, it's that notion of kind of herd immunity, that, it takes all of us to do that. It's not just that individually, once we get it, it's done. So I wonder, maybe you could close on kind of any final message that might be beneficial for folks to hear. And then I might do some kind of cleanup final comments on behalf of the CSA.
Sure. One thing I've seen over the 10 months and 11 months that we've been in this is that, initially in the first few months that I've seen in patients, and they were saying, "Oh, thank you for the good work," and I know you're doing a great service and all of that. You can see that there is some difficulty because they are not able to come to the appointments and things like that. But still, they're hoping for a good outcome out of all of this. But as the months of isolation and loneliness increases, we are not getting the time to interact with people that we're used to. No family time, things like that. It's really getting on the mental health of a lot of individuals. I can see a lot of people are getting short-tempered and losing patience fast, and some amount of sadness. And this is not the time to really lose hope. We have as mankind has really made huge progress with this rapid development of a vaccine that has really stepped up to the plate, and here we are with multiple vaccines being ready within a year of a pandemic. We will be out of this. We are in this together. We'll be out of this together in a few months. Just don't lose hope. That's all that I want to say. And be an advocate. Be an advocate for science. If you see anything that is pseudoscience or pseudo news, don't forward it to the next person. Just ignore it. If somebody comes to you, then speak. Just support science and be patient, and we will be out of this together.
Yeah, excellent words to conclude. Yeah, we really appreciate your time, Dr. Haroon. I think one point that I really want to pick up on is this notion of mental health. And we in last I think May or so had a webinar with one of our close colleagues and specialists talking about chronic illness distress and kind of the already heavy mental load that many of us navigate with autoimmune or kind of chronic conditions. And so I think what's part of this message is that these are normal feelings to have, especially given all of this kind of uncertainty. And we'll be doing our part at the CSA to try to have more of those sessions focused on how do we cultivate to the best of our ability a positive mental state, recognizing that oscillates every day, right? We know we all go through good times and bad times. And so hopefully, we'll be able to continue to provide those resources. We have them on our website if you're interested to listen. We also have recorded this, and we'll put this presentation up on the website, including Dr. Haroon's slides, if he's comfortable with that. I know we had a lot of questions on that. I really, I think want to end with sharing our, appreciation to you, Dr. Haroon, and to the broader Spark network for supporting, our work at the CSA, making sure that, we're providing the best information that we can. And it's, it's an honor to share this kind of virtual circle with you, and it's an honor to share with, everybody on the line. My final plug is, to help continue this momentum, to support the work of the CSA. We have a newsletter that any of you can sign up for, that we can circulate this type of information to you for. We are, regularly trying to hold these different types of events. Obviously, there are specific questions that you need to address with your medical professionals. And trust me, I recognize the challenge with doing that. The kind of annual meeting that I have with my rheumatologist, it's not as easy as we make it out to be, but kind of rest assured that we all navigate that. And then also that, we'll continue to adapt to the circumstances that you're feeling. And if there are specific things that you want us to kind of dive into a little bit more detail, with the help of experts like Dr. Haroon and others, we can try to respond to those different questions. So, with that, I think I maybe just offer you the final word, Dr. Haroon, and then we'll close the webinar for today.
Thank you. Thank you, Graham. Thank you, CSA, and continue doing the great work that you're doing. And hopefully we can continue our partnership in the years ahead, in the non-COVID world too.
Yeah, exactly. Maybe at one point we can do this in person. So yeah, Chimigwech, everybody, stay safe. I think the line of action and vaccinations is an important message to end on. Really appreciate all the incredible questions that we've had in the chat and the Q&A. And, we'll do our work also after the webinar to try to, summarize and find key themes within those questions. And if we can do more on, the website that we have a specific section on COVID-19, we'll try to update that as much as we can. So, really appreciate all of you who have tuned in. Really appreciate you, Dr. Haroon. Want to give an important shout out to Wendy, Ed, and Dan for all the work that they did in organizing this. And yeah, look forward to seeing you on our next webinar, and maybe an in-person session at some point. So stay safe. Thanks, everyone.